Hello, and welcome to the AMCA Young Professionals' latest installment of our webinar series, Delusory Parasitosis, Understanding How This Gets Under People's Skin. My name is Levy Sun, the past chair to the Young Professionals group, and I'll be introducing our speaker, Dr. Hinkle, and facilitating the questions and answers portion at the end. But before we begin today's presentation, we have a few housekeeping items. First, if you have difficulty with audio, you can call into the meeting at any time using your phone. The number and PIN will be listed in the chat box on the left side of your screen, and I will paste it in right now. For those who need audio cues, the number is 706-913-1155, and the PIN will also be posted right now, and that PIN is 4191312#. Next, during the presentation, you may submit questions to the presenter via the chat box. Questions will be answered at the end of the webinar during a Q&A session. And third, there will be a quick survey at the conclusion of the webinar. If you have an idea for a webinar topic or a comment, please let us know. And now it's time to introduce today's speaker, Dr. Nancy Hinkle. Dr. Hinkle is an extension veterinary entomologist for the state of Georgia. Dr. Hinkle is charged with research and public education regarding domestic and companion animal ectoparasites, as well as pests of livestock and poultry. Because people frequently assume that they have become infested by parasites transferring from their pets, she is regularly contacted by individuals suffering from Ekbom syndrome, also known as Delusory Parasitosis, which is a condition where people think their bodies are infested with invisible bugs. So, without further ado, it is my pleasure to give the floor to our presenter, Dr. Nancy Hinkle. Whenever you're ready, Dr. Hinkle.
Good day, everyone, and thank you, Levy. I really appreciate that introduction, and thank you to all of the young professionals who are allowing me to present this webinar. Working in vector control virtually guarantees that sooner or later you will encounter a citizen who thinks they're infested by bugs, and they will expect you to do something about it. This condition is called delusory parasitosis. This is the delusion that one's body is infested with invisible bugs. These people are not malingering. They are not pretending. They are not imagining. This is a true delusion, and they are absolutely convinced that they're infested. Now, before I go into delusory parasitosis, let me step aside for a second and mention another condition that is similar, and you may run into it as well, called Morgellons. Now, Morgellons actually has a lot of followers. If you have nothing else to do some afternoon, Google Morgellons, and you'll find thousands of websites dealing with Morgellons and people who think they're infested with fibers. This is the fiber disease. There are many websites, as I mentioned, and they will tell you about the symptomatology and the treatments. This is another delusional condition, but instead of being infested with insects, these people think they're infested with fibers. Books have been written about Morgellons, and not to understate the condition, you can see the title there, Mystery Disease, Delusion, or the Next Global Pandemic. These people are quite adamant that, again, they are infested, but they think they have fibers growing in their skin. A few years ago, the Centers for Disease Control actually funded a study looking at Morgellons. The results of that study have been published under the title, as you can see at the bottom of the slide there, Clinical, Epidemiologic, Histopathologic, and Molecular Features of an Unexplained Dermopathy. You need to read this for yourself, but the conclusion in general was that most of the people suffering from this condition tested positive for the use of various recreational drugs. But back to Ekbom syndrome, or delusory parasitosis. Generally, we entomologists refer to it as delusory parasitosis. That's the title that's been used in the entomological literature for the past 100 years or so. Clinically, it's called Ekbom syndrome. My psychiatry friends have told me that the term delusory is stigmatizing and that people don't like being told that they're delusional. I can understand that. So we use the clinical term Ekbom syndrome when we're trying to be more appropriate, but you'll find me lapsing back into calling it delusory parasitosis because there is such a tradition of that. And again, this is a condition in which the individual considers himself to be infested by invisible bugs. The gentleman shown here was convinced that his body was infested with invisible bugs. He would take his pocket knife and dig tissue out of his skin, put it in envelopes, and ship it to me so that I could look for the bugs that were there. After 6 or 8 months of doing this, I had still not found an insect coming from his skin. But as you can see, he had done a lot of damage to his skin. And the last time I heard from him, he was still convinced that he was infested, and I was just incompetent and unable to find the bugs that he was sending to me. Now, in this talk, I'm going to use the term infestation in a more restricted sense than you're probably familiar with. In this case, we're going to talk about an infestation as a population of organisms that lives in or on the host, but they sustain themselves on the host. They feed on the host, they reproduce on the host, and each generation subsequently occurs on the host. That is, this organism cannot live off the host, so it is a true parasite dependent on the host. And again, delusory parasitosis or Ekbom syndrome is an erroneous, unshakable belief that the skin is infested with a parasite. Now, obviously, if someone has head lice, they are truly infested with head lice. That is a true infestation. The lice are feeding on the host. They're reproducing on the host. The generation after generation is occurring on the host. But if it's an erroneous assumption, it becomes a delusion. And a delusion is a false belief that is not consistent with the patient's intelligence, their educational level, or their cultural background, and that cannot be corrected by reasoning. And notice that last part there. It cannot be corrected by reasoning. Now, we're scientists. We're used to using data. We're used to using rational thought. These people cannot be convinced. You cannot show them enough evidence. You can sit them down at your microscope with all of their specimens. They can look at them. They still will not be persuaded that they're not infested. So this is a true delusion. It's a mental health situation. Why is it called Ekbom syndrome? Dr. Ekbom was a Swedish neurologist who wrote a paper back about 60 or 80 years ago called Delusion of Infestation in the Elderly. It's available online if you want to read it. And it describes very well exactly the phenomena that we encounter today of these people who think that they are infested with invisible bugs. And therefore, the condition was named after Dr. Ekbom. So how do you, vector control people, become involved with invisible bugs? Well, again, your profession is people-focused. While you may think you're going to spend your time controlling insects, inevitably you will find yourself spending a lot of your career dealing with people. And unfortunately, these people who suffer from invisible bug infestations will not always be at their best. They can be very contrary. So these are the sorts of emails you may receive. These are just a few that I've gotten myself. Dr. Hinkle, I've been suffering from what feels like insect bites at night, but can't ever see any insects where affected. Every so often I think I see something flying past me, but have still never found one. I used a fogger for my apartment, and while it seemed to work for a few days, the culprit is back in full force. I also just recently returned from being out of town for 4 days, thinking the lack of a blood source would starve whatever it is, but only seemed to make them hungrier. I feel like they are crawling on me, followed by an intense sting, bite, then a little welt forms that, when scratched, turns into a scab that doesn't heal quickly, as in 1 to 2 weeks before they finally go away, the scabs. Nothing I've found on the web has been helpful in pinpointing what I'm dealing with, and I was hoping you might be able to steer me in the right direction for relief. So there you've got somebody who thinks they're being infested. They're trying to starve the creatures, but the creatures are still there. They can't see them, but they are having dermatological manifestations, which convince them that there really is something there. Here's another. Help! I'm being eaten alive by invisible bugs. When I'm being bitten, I feel a sharp sensation like a tiny pinprick, but when I look at where I'm being bitten, I can't see a darn thing. I have tiny red dots all over my body, under my skin, where I believe the bugs have bitten me, But my doctor says they're probably nothing. Whatever, doc. There is no welt or noticeable bite mark. I feel itchy all over my body, my feet, my belly, my hair, especially when I'm in the basement and at night. I know this isn't in my head because when people come over to the basement, they are itchy too. Also, I believe it's a bug that jumps because when I am around someone else, they start to feel itchy as well without me saying a word about the bugs. I've sprayed the place enough times, vacuumed and scrubbed for hours, washed my sheets and clothes in hot water twice, and bagged them, then froze them, and have now just resorted to spraying off on myself. And when I'm really desperate, raid before and after bed because this is the only way I get relief. Does anyone else battle this same mysterious bug? Any advice? Please help. And here you get a sense of the desperation. These people will try anything. They use the fact that other people occasionally scratch to convince themselves that they are sharing their infestation with people around them. They do some outlandish things like putting their clothes in the freezer, and even then they don't get relief. Now, I don't know if you know of any arthropods that can survive long-term exposure to sub-freezing temperatures, but there aren't many out there. If you put your clothes in the freezer, you're pretty much going to kill anything that's alive there. But this gives us a little perspective on what these people think they're going through. Now, here's another one. This is one that I found on the web. Hi, battled this affliction for months myself. After much research, found triclosan powder on eBay from that location. I put in shower gel, liquid laundry, and fogged with it. My nightmare finally over. I used in conjunction with internal protozoal meds for internal cleansing. One thing for sure, if you don't treat inside and outside environment together, you will be reinfected. These mites are in your environment. The adults are on the outside of skin, biting, feeding, and mating. They lay eggs under your skin. The crawling, wiggling you feel is from eggs hatching and larvae stage. Their life cycle from egg to hatching stage is only 3 days. Must fog every 3 days to break this cycle and get them all. Use your lotion on body every day. This will cure you. So, not only is it an arthropod, but apparently it's a protozoan as well, and you have to attack it in various ways, or at least that's claimed by this sufferer. Now, people who have this condition come up with all sorts of explanations for what they think is infesting them. Some people think it's springtails or columbella. Some people think it's no-see-ums, the culicoides biting midges in the family Ceratopogonidae. Some think it's bed bugs. Bed bugs have been getting a lot of attention. Some think it's scabies mites. Some think it's chiggers. And some people think it's bird or rodent mites. And believe me, just about every other arthropod out there has been considered to be the source of the infestation that someone has suffered with. Frankly, it seems that the less someone knows about entomology, the more likely they are to pick a pet insect and make that the insect that's infesting them. Unfortunately, with the web, they can do enough research to learn the jargon, but they don't really understand the biology or what arthropods can and cannot do. For instance, springtails. Unfortunately, there is a publication on the web that claims that springtails can infest human bodies. It's a long, sordid story, but this paper has been debunked by several subsequent publications. And the consensus is, by scientists who study columbella, that it is impossible for springtails to infest human bodies. However, because the paper's out there, we will continue to have to deal with it because people who suffer from infestations will find this publication and use it to try to convince other scientists that that's what they're infested with. But anyone who's really worked with springtails knows that they really cannot live in human bodies. How about no-see-ums? If you're infested with something that you cannot see, when you come across the term no-see-um, you instantly say, that must be what it is. If I can't see it, that's what's infesting me. Of course, you folks working in vector control know that no-see-ums are very common insects. They're everywhere. They can be seen. They're not invisible. They almost always are found in specific locations around water. They're very common on beaches. They're seasonal. and they're never found indoors. You don't have to worry about no-see-ums moving into your home and infesting your house and your body. Bed bugs. Bed bugs are a whole nother story. Yes, you can have an infestation of bed bugs in your home. They don't infest human bodies, however. They're like mosquitoes in that they come to our bodies at night, they take a little blood meal, and then they crawl away. They do not spend a long time on the host, and they certainly do not infest our bodies. Another thing is that bed bugs are not invisible. As you can see, they're quite visible. They're large enough to see easily with the naked eye, and they are not going to do the sorts of things that we read about in those emails. They're not going to infest us 24 hours a day. Now, scabies mites. You probably had enough entomology to realize that scabies mites truly do infest human bodies. They are specific to human bodies. You can only get scabies from another person who has scabies. You're not going to get scabies from a toilet seat or from shaking hands with somebody, probably. You're just going to get scabies from prolonged contact with somebody who has the scabies infection. Now, other animals can have scabies, but they have different strains that are unable to infect humans. So you're not going to be infested by scabies from a dog or scabies from a cow or scabies from any other animal. You, again, can only get scabies infestations from another human. Scabies is a medical condition. Someone suffering from scabies must be treated by a physician. This is not an entomological challenge. This is a medical challenge. If someone thinks they're infested with scabies, they need to consult with their physician, be properly diagnosed, and then the treatment should be prescribed by the physician. This is not something that we in vector control should have to deal with. Chiggers are another mite. Scabies are one type of mite. Chiggers are another type of mite. Chiggers infest mainly small herps. They live on lizards and snakes and things like that. But sometimes they get confused and they end up on human skin and they attempt to feed on us. They don't do well on us. Pretty much they're going to die within 24 hours because whatever we provide them with is not adequate for their survival. So they're not going to be able to survive on us, and they're going to die within a few hours. But while they're attempting to feed on us, they are injecting our bodies with a salivary secretion that for some reason sends our immune system into overdrive. People who have been bothered by chiggers will claim that this is the most severe itching they have ever experienced. So if you want to try out a truly incredible case of pruritus, go and get in a chigger habitat and let a few chiggers attach to your skin and see what that makes you feel like. But again, this is not something that accounts for the descriptions that we read earlier. Chiggers, again, are seasonal. You're not going to get chiggers at Christmas. They're strictly outdoors, and they're only going to be in habitats where you would find small herps, lizards, and snakes and things like that. So this does not account for delusory parasitosis symptoms either. Birdmites.org, that's another website you can check out sometime when you have nothing else to do. This website is dedicated to finding effective solutions for bird mite infestations of humans in their environment, encouraging those afflicted, facilitating research, and a better understanding of human parasitosis. People who develop this website and the people who go to it are convinced that bird mites, avian mites, have recently evolved the ability to live on mammals. And this is just not biologically true. Avian mites are very well adapted to their avian hosts. They can live on birds and only on birds. They cannot live on other mammals, including humans. Nevertheless, you will find people claiming that bird mites have infested them. Now, I've been working with avian mites for over 30 years. I've been covered in avian mites, and I have yet to become infested. They do not reproduce on me. They don't live on me. They cannot survive on me for more than a few hours. This is what bird mites look like. They are not invisible. They are large enough to be seen with the naked eye. Yes, they do give you a creepy sensation when they're crawling around on your skin. Yes, they will attempt to bite mammals, but again, they cannot survive on our blood, and so they will starve to death within a few hours. But they can make you itchy. I don't react to their salivary secretions, but some people do. So this is something to look for. People who think they are infested should have their home inspected for bird mites, and that could be a valid explanation for their sensations if they're feeling the sensation of something crawling on them and or the sensation of itching. However, this is a rare condition. This is not something you're going to find in every home. The bird mites have to get into the house. They have to come from a living bird. And again, this is going to be seasonal. You're not going to have bird mites crawling into your house at Christmas. And it's going to be a self-limiting condition. They cannot live forever without a blood meal. And since they cannot survive on mammalian blood, they will not be able to perpetuate their populations on the human occupants of the home. Yes, if you deal with delusory parasitosis, you too can receive boxes coming into your office with these sorts of containers. As you can see, a lot of drug containers, various other materials, and each one of these had a sample of a bug that the individual thought was infesting their body, or so they claimed. When examined under the microscope, it turned out that most of the material in these containers consisted of various types of skin debris, dry skin, hairs, scabs, dried blood, or other materials, various debris such as you might find on your floor, fragments of plants, and other trash. There were no insects that can infest, bite, or sting a human body. But you can spend hours looking through these materials to determine whether or not there's a valid claim here. This is the sort of material typically you find: dried skin, scabs, dried blood, things that people have ripped off their body. Yes, if you find callous tissue, you can pull it off and you can put it in an envelope and send it to me, but that will not convince me that you're infested with bugs. We try not to let people come to the lab and show us their symptoms or signs. I don't have the time to deal with these people. I am not a medical doctor. I am not authorized, nor am I inclined to look at someone's body. However, occasionally someone will find me. This lady found us. We brought her into the lab. We set her up with a microscope so she could look and show us the bugs that she was claiming infested her skin. When she got into the lab, she sat down and reached into her purse, and I said, okay, now show me your bugs. So she pulled out a pair of tweezers and started to pull off one of the scabs on her arm. And I said, wait, what are you doing? And she said, well, I have to take off the lid so they can escape. They're underneath the lid. So to show them to you, I'm going to have to remove the lid. She was calling these scabs the lids to these wounds. Her sister, fortunately, had accompanied her for the visit that day, and her sister looked at me and she said, yes, this is what she does every night after dinner. She sits down with her tweezers and she pulls off all the scabs. So it's no wonder that she has these scars and this damage to her skin that will never resolve completely. Interestingly, this lady is a registered nurse. She's been trained in medicine. She knows better. She knows these are scabs. She knows there are no insects that infest the human body and does the sorts of things that she claims they're doing. But this lady was going through a very rough time in her life. Her husband had recently been injured in a major automobile accident, and he was in a rehabilitation center in another state. She was the sole breadwinner for the family meanwhile. She had a couple of teenagers still living at home with her. She was taking care of them while working full-time. Her daughter's best friend had just been kicked out of her house because she wasn't getting along with her parents, so she was living with them as well. This poor lady had 3 teenagers in her house. You can imagine the angst that was going around that household. And again, she was working full-time, trying to keep the household afloat and visit her husband when she could. So she had a lot of stress in her life. And we are working under the hypothesis that stress is one of the major psychological triggers that brings on this condition. I am an entomologist. Please remember that anything I say about medicine, psychology is out of my depth. But after 30 years of working with this condition, I am conjecturing that there are psychological triggers for the sorts of conditions that we're talking about here. A little more background on delusory parasitosis. Interestingly, it's the most commonly reported delusional disorder, more common than people claiming to see Martians or leprechauns. And we think there's probably more than 250,000 cases in the United States at any time. In other words, there's a good chance you're going to get to deal with some of these people. This is a bizarre condition, and one of the most bizarre features about it is that often it affects people in pairs or groups in a shared delusion called folie à deux. And sometimes it can affect entire families or coworkers working in offices or other groups. To me, this is totally bizarre. How in the world can a psychological condition be contagious? And I use air quotes when I say that. But we have seen this. It's not at all uncommon for husband and wife pairs to suffer from it at the same time. Families, again, with parents and the children both experiencing the same symptomatology. This is intriguing. If you have an inclination to go to graduate school in psychology, let me encourage you to follow up on this. I would love to know how this phenomenon works. And again, as we talked about, a delusion has no predilection for people of a particular socioeconomic level, ages, or anything like that. Dr. J. Traver was a prominent entomologist back in the middle of the last century. She was actually head of the Department of Zoology at the University of Massachusetts Amherst for a while, and yet Dr. Traver suffered from delusory parasitosis. In fact, she published this paper here, Unusual Scalp Dermatitis in Humans Caused by the Mite Dermatophagoides, to prove that she herself was infested. In this paper, she describes the symptoms that she experienced, and she actually provides an illustration of the mite that she recovered from her own scalp. It wasn't until decades later, when an acarologist perused this paper, that it was determined that the mite that she had found and illustrated in her paper was actually the common house dust mite, found everywhere, not at all unusual. It was not infesting her scalp. It was just a contaminant. I think you could probably find millions of house dust mites probably in the chair that you're sitting in. So it's actually more surprising that she didn't find more of these mites than that she actually found one. House dust mites, as you know, live on dead skin scales, so anything that we shed off of our skin, that's what they eat. Or actually, I think they eat the fungus that's growing on the skin scales. They do not live on human bodies. They cannot survive on living skin. They only infest or feed on dead skin. So this shows very well that even an entomologist can suffer from the delusion of being infested with invisible bugs. Well, we get calls about this frequently. I'm up to about 1 or 2 a day now, and that's taking a lot of time. So I've actually hired a psychologist who does nothing but sit there day after day and talk with people about their invisible bugs. And since they're going to be calling us anyway, we've started a study where we're investigating, or keeping records anyway, of demographics, symptoms, people's management behaviors, their medical histories, and potential comorbidities, trying to get some baseline data on this condition. It's hard for an entomologist to study something like this. It's not like we can go out and select a population and divide them into the infested individuals and the uninfested individuals. There's something morally repugnant about telling somebody, oh, you must have invisible bugs, when they don't. But since these people are coming to us anyway, we're trying to develop some background information on them. And hopefully someday the medical profession will step up to the plate and take on the study of these individuals. And that would be certainly more appropriate, because this is a medical condition. What have we discovered so far? Well, it's not surprising that this is most common in the elderly. Dr. Ekbom himself noticed this, that the people suffering from it are generally over the age of 60. They are disproportionately female. Our callers are almost 2 to 1 female to male. These people exhibit all sorts of self-destructive behaviors. Most of them have quit their jobs, and they give us a couple of reasons for this. One is that they don't want to be out in public potentially infesting other people. They do feel the moral quandary there of the risk of letting other people develop the condition that they so despise themselves. And secondly, most of these people spend hours every day trying to eradicate the bugs that they think are infesting them. Now, I haven't made this explicitly clear, but most of these people not only think that their bodies are infested, but they think that their homes are infested as well, so that even if they are able to eradicate the bugs on their bodies, they get reinfested from their furnishings, from their beds, from their clothes. If you remember the email that we started out with where the person was taking their clothing, freezing it, that's when they were trying to eradicate the infestation in the environment around them. So secondly, these people are trying to eradicate the infestation in their home, and this takes hours every day. They go around spraying Clorox on the walls and the ceiling and all the furnishings. If that doesn't work, sooner or later they will burn or destroy their furniture. Yes, they throw away everything that they own because they think that's the only way they can get rid of the bugs that are infesting their home. If that doesn't work, eventually they end up abandoning the home. If they can't get rid of the bugs, they figure they will just flee from them. So these people move into live with friends. When that opportunity runs out, then they move into a hotel. As you can imagine, they quickly go through their life savings, and then they end up living out of their automobile. We have dealt with many people who owned nothing in this world except their vehicle, where they lived, and that's all they did. They no longer had a job. Their family had disassociated themselves from the sufferer, and they were pretty hopeless, you can imagine. Again, when they're trying to eradicate the infestation in their home, they spend hours obsessively laundering their clothing, cleaning the home. They will use any pesticide that they can get their hands on. As you know, with the Internet now, we have availability of almost anything. If you want to buy something, there's probably somewhere that's selling it. So they will buy agricultural pesticides and use them full strength on their home. Some people will even bathe in them. So there is tremendous risk of pesticide exposure to this subpopulation just because they are so desperate. In addition, they will use all sorts of home remedies. They will use all these new and upcoming home remedies, anything that's popular, yucca, tea tree oil, all these things they will try. As you've seen from the photographs, these people will exhibit self-mutilation, excoriation, trying to dig the bugs out of their skin. And then they will provide me with these specimens, which generally are gobbets of tissue and various types of debris. Interestingly, most of these people can provide elaborate descriptions of the pest and its life cycle. Again, they've gone online, they've learned the jargon, they know about larvae and pupae and cocoons and emergence times and so on. And they will describe the infestation and even draw pictures of it. They experience social isolation. You can imagine. Think of being married to someone who spends 24 hours a day talking about their infestation, doing weird things to the house, burning the furniture. Most people's tolerance would only last so long. Even working with someone like this could be trying. As I mentioned earlier, we think that there is a psychological trigger, generally something like a major life event such as divorce, loss of a family member or friend, maybe job loss, that triggers these onsets of delusory parasitosis. Don't know why. Again, I'm not a psychiatrist, so I don't understand the underlying symptomatology here, what brings this on. But we do see when we talk with these individuals that almost all of them have experienced some major life event immediately prior to onset of their symptoms. Generally, by the time they come to us, they have consulted several physicians. They've been to their general practitioner. They've been to the emergency room. They've been to the health department. They've been to a parasitologist. They've been to an emergency medical type person. They've been to dermatologists. They've been to parasitologists. I think I've already mentioned that. Anyway, they've been to many different physicians. Most of the physicians have looked at them and said, oh, well, you probably have bugs, call your pest control company. Other physicians will say, well, it looks like scabies. Here, try this, put this cream on, that'll take care of it. I am concerned that physicians are not spending the time with these patients, accurately diagnosing the condition, and certainly they're not treating the condition. Frankly, most physicians have never heard of this condition, and you think about it, most physicians don't have much training in entomology. In fact, if you go through most physicians, their experience with entomology consists of maybe 1 or 2 lectures in medical school where they talked about mosquitoes and maybe ticks, but they didn't cover any other insects, so they really have a very poor understanding of any arthropod, and certainly they don't know anything about arthropod infestations of human bodies. So when they get to us, they are convinced that they're infested. The doctor has told them that it's probably scabies, so they want me to tell them how to get rid of scabies. Well, I am pretty sure that they don't have scabies. It's because scabies don't do the sorts of things that these people are describing. Scabies mites burrow under the skin. As you know, the only symptoms that you get when scabies is some little red tracks in the skin with severe itching. That's one thing about scabies mites, because they live in the skin, they defecate in the skin, they shed their exoskeletons in the skin. Our immune systems react very strongly to all this excreta, and so we end up with severe pruritus. So really the only symptom you have with scabies is pruritus, and doctors should not reinforce these people's delusions when these people claim that they see things crawling on them, or they see things flying, or they feel things crawling on them. You don't feel scabies mites crawling on you. They're microscopic. They're under the skin. You don't feel the sensation. Anyway, I have some bones to pick with physicians, if you've probably gathered from that rant. Again, by the time they get to us, the mean duration of the delusion has already been over 3 years. We don't know how long they continue to suffer from the delusion after we've dealt with them. Most of these individuals, as you gathered from the emails that we read, complain of the crawling sensation in their skin, sometimes a stinging sensation, maybe a biting sensation, and occasionally itching sensations. They are adamant that it's an infestation. You are wasting your breath if you try to convince them that there's any other potential causation. They use the term desperate. If I answer the phone and the first sentence I hear is, Dr. Hinkle, you have to help me, I'm desperate, I have a pretty good idea where that conversation is going to go. Even people who are suffering from horrendous situations like bed bugs or malaria exposure hardly ever use the word desperate. But people suffering from invisible bugs, that's the term they use. And as I alluded to earlier, it's not uncommon for these people to share their delusion with someone else, generally a family member or close friend, someone they spend a lot of time with. As I mentioned, they will treat themselves with just about anything. We've had people mention that they bathe in insecticides. They treat their skin with kerosene, with vinegar, with peroxide, with alcohol, with gasoline, benzene, all sorts of carcinogenic materials. But they are so desperate, and they are, for some reason, think that these materials will kill the insects. If they didn't have skin damage to begin with, you can imagine what the skin looks like after they've exposed themselves to these materials. Now, in general, people who have dealt with this condition seem to believe that the sensations are real. In the materials that I've read published by entomologists and the limited material that's been published by physicians, it seems that the consensus is that these sufferers are actually feeling something. The debate is about what is causing the sensation. Is it a physical stimulus? Is it a physiological stimulus? Or is it a psychological stimulus? Certainly there are many causes of skin discomfort. Drying skin, you have these creepy, crawly sensations. We put materials on our skin that can make us feel skin sensations. Then there are physiological causes of skin discomfort. You've got all sorts of infections, bacterial, viral, fungal, and so on. I won't even go there because you know there are so many different diseases that produce skin discomfort. Formication, of course, comes from the term for ants, formica. And Diabetic neuropathy is one condition that may be producing sensations. It's a serious complication of diabetes affecting half of diabetics. Nerves damaged by diabetic neuropathy can cause stinging or burning sensations, tingling, pain, numbness, or a crawling sensation on the skin. So perhaps there are some physiological underlying causes of the sensations some people are experiencing. I am conjecturing at this point. I am not saying this is true. I am just trying to find some reason that these people may be experiencing skin sensations. Here's a bunch of other diseases that are characterized by formication, paresthesia, or pruritus symptoms. Formication, again, the crawling sensation on your skin, feels like bugs are crawling on your skin. Paresthesia is that prickly sensation on your skin. Pruritus is just itching. And if you look at the top 10 prescription medications that are used by Americans, you'll notice that every one of them has one of the sensations that might be attributed to delusory parasitosis. In addition, the majority of them, the vast majority of them, can also cause hallucinations. In our drug-using world, especially our American society, where 1 in 6 Americans over the age of 60 took a psychiatric drug in this past year, there's a good chance that somebody has taken one of these drugs and experienced a side effect, such as the creepy crawling sensation on their skin or formication, along with a visual hallucination where they think they see the bug that's infesting their body. Again, this is a theory. I'm just trying to find some reason for why these people are feeling these sensations. Okay, that was the prescription drugs. Everybody takes over-the-counter drugs as well. What's the chance of side effects from these or their interaction with other drugs? Not to mention the recreational drugs. As you know, our population certainly is using all sorts of illegal drugs now. And the medical profession, as well as the law enforcement group, certainly uses the term cocaine bugs and meth mites. So people who have used these drugs, cocaine, may be experiencing cocaine bugs, the sensation of bugs crawling on their skin, and probably even more pervasive, meth mites. We've got people now using meth. They've certainly got problems. If they don't have other problems, they've got invisible bugs now infesting their skin. So we have to consider the possibility that people are bringing on this infestation, quote, quote, themselves. Again, cocaine, as you see over here, you may hear voices talking to you or see bugs crawling over your skin. So we have to consider that potentially people experiencing Ekbom syndrome may have been using illegal drugs and may be experiencing these sensations. For instance, this fellow here complained of a worm infestation in his neck. He used a pair of scissors to excise the imagined worms. Not surprisingly, the toxicology screening of this patient was positive for cocaine, opiates, and tranquilizers. So he had severe problems. You got to figure anybody who will go to that length has some problems. Now, as I've mentioned several times, we are working under the hypothesis that psychological causes are stimulating the onset of these symptoms. If you look through the dermatological literature, you see that stress, anxiety, and or depression frequently manifest themselves dermatologically. So, what can we do? We're not doctors. We're not medical doctors. My only real responsibility is to determine whether or not there is a pest there. And certainly for people in vector control, this is the first thing. Find the pest and identify the pest. If there's no pest there, the first rule of integrated pest management is not to make a treatment until we've identified a pest. So what I ask the sufferer to do is to carry a roll of clear Scotch tape with them at all times. When they feel the sensation, take a small piece of the tape, stick it to the area. Logically, anything that's crawling on the skin there will become entrapped in the adhesive on the tape. Then fold the tape over on itself, box it up, and ship it to me. I'll put it under the microscope, and I will identify whatever's causing the sensation. Generally, this is what I find when I put the tape under the microscope. In the upper left-hand corner, you've got a piece of carpet fiber that's broken off. And the rest of them are scabs with hairs entrapped in them, although the one on the lower right-hand corner there is actually a hair follicle. If you play around with your hair and then you pull a hair out from under from your arm and you stick it under the microscope, you'll probably see the hair follicle. It looks something like that. Yes, it looks like a worm or a little snake, but it's just a hair follicle. If you know enough about biology, you know there's a lot of neat things in our bodies that most people are not familiar with. So, what would I recommend? Should you go in and make an application when these people complain that they're infested with bugs? I strongly recommend against that. While the placebo effect does produce temporary relief, typically the symptoms will return more severe than before. Not to mention that it's probably ethically questionable to lie to people and to do something deceptive like to use a non-effective treatment. And let me remind you that once you tell someone that you're treating for something, you have validated for them their belief that they are infested. And I think you've entered a moral questionable area there because at that point you seem to be obligated to do something about their problem. So when you think about it, there really are only two arthropods that truly infest human bodies, the human louse and scabies mites. And I'm kind of cheating here because there's three different types of human lice: head lice, body lice, and pubic lice. But these are really the only arthropods that infest human bodies, and they live exclusively on human bodies. So there's no role for pest control or vector control in their treatment. They are strictly medical conditions. If someone is infested with scabies mites, all you can do is refer them to a physician. If they're infested with lice, then it's a medical condition and they need to visit a physician. Let me summarize by saying there's no insect or mite that can live in the environment and switch to infesting the human body. Think about that. You're not going to get infested from the carpet or from the walls or from anything around your home. There's no insect or mite that can feed on inorganic materials, so they can't survive on furniture or carpeting. They can't eat nylon. They can't eat steel. There's no winged insects that infest human bodies, so when somebody says that it flew out of my ear or it flew out of my skin, there's nothing that pupates in the human body and then develops wings and flies away. There are no invisible mites or insects that infest human bodies, and actually I could cut that much shorter and just say there are no invisible mites or insects. Microscopic, yes, but not invisible. There are no external animal parasites that can infest humans. You're not going to get a parasite, an external parasite, an ectoparasite, from a dog or a pigeon or a cow or a horse or a cat or a squirrel or any other animal. You can get some internal parasites, but just be careful what you eat. Bird mites cannot infest humans. They are strictly avian feeders and cannot live on any mammals, including humans. Human body infestation is a medical condition. It must be treated by a physician. There's nothing we in vector control or entomologists can do. It's only treatable by a physician. One thing I would ask is do not call the wounds bites. Again, you are an authority figure. If you say it's a bite, that implies that there was an arthropod there with mouth parts that penetrated the skin. And unless we know there was something there with mouth parts, we don't know that it's a bite. So use terms like lesion or wound or sore. Those don't obligate you to an infestation. You are the expert. Don't believe everything that the sufferer says. These people are giving you their perspective. These are not necessarily factual. It's your job to monitor and evaluate. We treat only for insects when a target pest has been found and identified. We need to think about the consequences of our decision because, again, what we do influences what the sufferer thinks. Here's one last individual who we've dealt with. This lady thought that she had a bug, or actually a worm, living in her cheek. As you can see, there was considerable damage where she'd been trying to extract the worm. She would put hydrogen peroxide on the wound, and this would drive out the worm eggs. This is what she thought she was seeing here, worm eggs. She was eventually able to extract a worm, and this is what the worm looked like. She provided excellent photographs of the worm. Of course, it's not actually a worm. It is her dermis and subdermal tissue that she had ripped out of her cheek there. As you can see, she's tried to cover over it with makeup, but she's going to have a scar there that will never completely resolve. Interestingly, delusory parasitosis has entered into popular culture. You can get the movie Bug, which talks about a drug-induced psychosis in which a couple of people suffer from folie à deux. Criminal Minds had an excellent episode about an individual who was infested with invisible bugs. And there are other programs that have used this subtext as well. But let me conclude by saying that Ekbom syndrome is a medical condition. There's nothing I, as an entomologist, can do for these individuals other than tell them that there's not an insect involved. I'm sure many of you have had to deal with this condition, and I would love to hear your stories as well. There's my email address up there, insects@uga.edu. If you could give me drop me a line, just a short synopsis of some of the conditions you deal with, I'd love to hear your stories. Every one of these individuals is different, and yet there are so many similarities. So again, thank you for your time. Thank you for your attention. There's my email connection, so if you want to drop me a line, I'd love to hear from you. And thanks again, Levy. I really appreciate your hospitality.
Thank you so much, Dr. Hinkle, for sharing your knowledge and your expertise in a very engaging way. At this point, we'll open the floor to questions. If you would like to submit a question, you may do so via the chat function on the left side of your screen. So let's go ahead and get started with the first question. We actually have a few submitted into the queue. The first one actually is, can you, Dr. Hinkle, repeat the name of the syndrome and the side of the paper you mentioned in the beginning, right before you mentioned the Ekbom syndrome?
Morgellons, 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 the fiber disease.
And was there the side of the paper that you had mentioned?
Yes, it's if you just Google Morgellons and CDC, or Centers for Disease Control, I think the paper will come up. It has gotten a lot of notoriety, a lot of coverage. It was a 2012 paper, but if you Google Morgellons, Centers for Disease Control 2012, I'm pretty sure it'll come up. All right, just email me and I'll send you the link.
Thank you. Based on your experience so far, do you think there's been an increase in the number of people in the United States with Ekbom syndrome over the years?
We have discussed that. Those of us who deal with it. As you can imagine, there's somebody in every state who's the sucker, the individual who gets stuck with these people. And we've talked about this. We wonder if there's actually more people suffering from it now, or if it's just that they have an easier time to find us because of the Internet. And they do have the opportunity to compare notes with one another through chat sites, web locations, email, and so on. I don't really know. That's the summary. I don't know.
Now, during your presentation, you had shown us the different demographics or profiles of folks who are more likely to have Ekbom syndrome. Which of those results actually surprised you the most?
I guess I am still astounded that a folie à deux, that more than one person in a household can suffer from the same condition. I just don't understand how the human brain works. That astounds me, yes.
Now, to follow up with that, because it can affect multiple people in the family, whether or not the other family members may have Ekbom syndrome, we're thinking about children, too, in the family. So have you ever had to call child services for any children that are possibly in danger from their parents experiencing Ekbom syndrome?
Interesting you bring that up. Yes, indeed. A couple of times we have had to do that, and that, frankly, is what disturbs me the most. Adults can do pretty much anything they want to their body. I would prefer that they not abuse their bodies, but you're grown up, you're responsible. I can't do anything about that. But when you start picking on children or animals, frankly, that's when I become concerned, and we have had to call child services occasionally for individuals where they were pulling bugs out of the child's skin or treating the child with materials that were risky.
Thank you for that. Let's go ahead and move into the lab where people come to see you. How do you deal with persons who consistently come to see you regarding this issue? Do you eventually refer them to a specific doctor? And if so, how smooth is that transition?
Oh, boy. We try not to let them show up. If you can avoid that, that's the way to go. If you've got a really good secretary up front that will keep them from making their way back to your office, that's the way to go. Frankly, here at the university, we don't let them know where we're located. We keep our location secret. I don't want these people coming to my lab. And referring them to a physician, that is what we have to do. Really, that's all I can say is you need to go to a doctor. Well, and their response is, Dr. Hinkle, I've been to a dozen doctors. Nobody will do anything for me. And that is an indictment of our medical profession, I'm afraid. These doctors should be picking up on this condition and treating it appropriately. I cannot do anything for these people, and doctors will not do anything for these people, and that incenses me, frankly. There's really nothing other than referring these people to the medical profession. That's the only way they will get the treatment that they require. There are medications that will cure this condition. These people will get their lives back, but they have to go to a physician. The physician has to prescribe the proper medication, and the individual has to take the medication for the 2 or 3 months that it's required for it to manifest the cure that it will. But that's not what entomologists do. I'm sorry, go ahead.
Okay, not a problem. It sounds like frustration is actually quite common for all parties involved, for the physician not understanding, to the vector control or entomologist not understanding or how to better provide a solution for this individual. And also for the individual themselves, it can be very frustrating. And it could come to a point where maybe they may become aggressive. So have you ever had any experience with aggressive or very upset individuals, and how would you handle that kind of situation?
Yes, and that concerns me. That puts my staff at risk, and that's why we make a great effort to keep our location secret. It's bad enough to have to deal with belligerent people over the phone, but I don't want the risk of them coming to us and perhaps threatening my staff in person. We think that most of these people, even though they are suffering from a mental health condition, are harmless. But we don't know that. We don't know what might tip someone past the point. And I don't want to risk that. So that's an excellent point, and my response, frankly, is I don't know. But that I would rather err on the side of being overly cautious.
And let's move into a more happier scenario where the person just perhaps one day may not experience egg bomb syndrome. Do these cases ever happen that way, where they spontaneously resolve themselves? And if so, what may happen to the person to cause them to be, quote, unhealed or, quote, healed?
I have never heard of one of those situations. It may happen because, again, we don't ever hear the rest of the story from most of these people. If they are healed, then I guess there's no reason for them to call the entomologist and gloat. But I have never heard of anyone spontaneously recovering from this condition. The only people I've heard who did eventually get well were people who went to the physician, got the prescription, followed the recommendations, took the medication, and eventually, usually after 6 to 8 weeks, regained their health.
Thank you for that. And we are running closer out of time, so last question. How did you come to work with egg bomb syndrome? Did it kind of fall in your lap because you were the most specialized in this or most knowledgeable in this?
I was actually a graduate student. My major professor came to me with a little box full of material, and he said, here, look at this and tell me what bugs you find. Well, being a graduate student, of course, you want to impress your major professor. So I looked through it. I spent hours at the microscope, meticulously looking through all the material, didn't find a single bug. Sheepishly went into my major professor's office and confessed that I couldn't find anything. He said, that's what I expected. It's a case of Delusory parasitosis. And frankly, that was the first time I had ever heard of this condition. It intrigued me, so I followed up on it, found the few publications that had been put out about it. And then once you get interested, people find out no one wants to deal with these people, so they started dumping them on me. When these people would call up, I think I've got invisible bugs. Oh, you want to talk to Dr. Hinkle? Her number is. And it just builds on itself. Once you've got the reputation as being the Delusory parasitosis entomologist, people are more than willing to share their clients with you.
Well, it sounds like the upside to all this is you're able to now share it with us.
I'm glad you look at it that way, Levy.
All right. Well, that does conclude the Q&A section of this month's webinar. To all attendees, once you exit the webinar screen, you'll be invited to take a quick survey. A recording of this webinar will be available later on the YP website. So that website is amcayps.wordpress.com, or you can just Google AMCAYPs, and you'll find our website there. A link will also be posted on our AMCA Young Professionals Twitter and Facebook accounts. So thank you again, Dr. Hinkle, for sharing your knowledge today. And to everyone else, we will see you at the next Young Professionals webinar, or maybe at the annual meeting next year. Thank you, everyone, and have a great day.
Happy holidays.